Welcome to this training on schizophrenia basics. This is part of a three-part series related to schizophrenia spectrum disorders and evidence-based care. These trainings are specifically designed for volunteer supporters and help provide more support and education about schizophrenia. Today, we wanted to share some of what we'll be covering. And first, we're going to introduce some of our presenters here. So on the next slide, you see a few of our colleagues here. They'll provide more in-depth introductions as they speak, but we have Deborah Rose, Mark Avery, and Dave Leon to share their different clinical perspectives of working with individuals with a schizophrenia diagnosis and other peers and family members, and their work in providing support for individuals with schizophrenia. So on the next slide, we just wanted to preview some objectives for you. So the goal is at the end of this session, you will have an increased ability to do a couple things. One is use specific language related to schizophrenia, including diagnosis and features. It helps to know the specific language to use when talking about schizophrenia and some of the contributing factors and how that will manifest in different individuals. We'll also explain the basic biology of schizophrenia and how it compares to other mental disorders. In the Part 2 and Part 3, we'll talk more about evidence-based practices and how to provide some support and some helpful tips for working with individuals. But this introduction is just providing some basic overview. So on the next slide, we'll just see what's on the agenda for today. So first, we'll have that high-level overview of significant disease features and diagnosis. We'll also review some of the disease progression and how it manifests and how it's diagnosed, and then compare it to some other mental conditions and talk about the goals of Care Act services. So with that introduction, I'm going to turn the time over to Mark Avery, Dr. Mark Avery, to introduce this section on schizophrenia basics. Mark?
Hi there. We have an important update regarding the Care Act beginning January 1st, 2026. Changes made by Senate Bill 27 will go into effect. These changes include bipolar I disorder with psychotic features will now be included as an eligible diagnosis under the Care Act, except psychosis related solely to intoxication. This law now defines what it means to be clinically stabilized and ongoing voluntary treatment. Certain court referrals can now serve as a care petition. Criminal courts may consider care referrals earlier for individuals found incompetent to stand trial in misdemeanor cases. Nurse practitioners and physician's assistants are now authorized to complete affidavits in support of care petitions, and there are also some technical amendments to streamline the care process. Our training PDFs, including the notes, have been updated to reflect these changes, including the addition of bipolar I disorder with psychotic features, and they are available on the Care Act Resource Center. But during this training video, you may hear older references to schizophrenia and other psychotic disorders, so keep this update in mind that it will now include bipolar I disorder with psychotic features starting January 1st, 2026, and other updates made by Senate Bill 27. Thank you for staying informed, and please review the updated resources linked in your training materials. You can find more information about these changes in our SB 27 brief on the Care Act Resource Center, or email us at info@careact.org.
Thank you, Patricia. I'm Mark Avery. I'm a psychiatrist, and over the years, I've worked with many hundreds of persons with schizophrenia and schizophrenia spectrum disorders and other psychotic conditions, both in the community setting, mostly in the community setting, but also in the hospital setting as well. To get us started, I want to let you know that we'll be referring to supporters throughout this training. When we use that term, it's in reference to those individuals that are providing care or providing support to care recipients. This includes volunteer supporters, family members, friends, neighbors, colleagues, etc. On the next slide, we're starting right off with the basics. So a bit of background about schizophrenia and schizophrenia spectrum conditions. They're relatively common conditions, but also can be quite serious. And it's a psychiatric disorder affecting about 1 in 100 to 1 in 200 persons in our communities in the United States. It's commonly referred to as a disease of the brain, but it primarily has symptoms that affect people's thinking, emotions, and actions. It's also very often portrayed incorrectly on television and in the media. So that often leads to a lot of negative beliefs and stigma about what it is, how it presents, how we can help, and how people can get the help they need. Persons with schizophrenia also can experience quite a bit of discrimination because of their condition, which, among other things, makes getting effective treatment and maintaining a place in their community more difficult. The goal of the first part of this training, as Patricia mentioned, is to cover the basic facts about the condition, including symptoms and terminology. With the next slide, we start off with an example of a person experiencing schizophrenia. This is not a real person, but it's just somebody to reference as we're going through some of the training that we're covering today. And I'd like to hand the microphone to my colleague, Dave Leon, to talk us through this case example. Dave?
Hey, thank you, Mark. It's nice to meet you all. Carl is a fictional character that we've talked about, but has a lot of traits of people that we've met over the years, the three of us who have had schizophrenia. Carl is a 64-year-old man. He's kind of an older rocker guy. He is always wearing jean jackets, and he always has a little dog on his lap, and he's petting that dog. He is kind of presents differently on different days. Some days he's very boisterous and talks about the old times, and sometimes refers to things about aliens having invaded our planet from other galaxies. And then on other days, he's much more quiet and much more reserved and much more cautious and nervous around people. He's lived with schizophrenia and has accepted that he has schizophrenia for a long time. He also has use of alcohol at times, sometimes to calm his nerves, sometimes to just escape. He has type 2 diabetes. He's currently homeless, but he has a couple friends on the street. He also is close to his older sister, who he uses as his volunteer supporter. He really tries to just keep a low profile in the world generally and keep to himself. He's often very, very uncomfortable around other people and new people. And he definitely has trouble meeting new people and connecting with new people. So he's a very interesting person to think about in our case discussion today. Thanks, Mark. Pass it back to you.
Thanks. Thanks, Dave. So let's go on to our next slide. When schizophrenia happens in a person, it's very natural to think, gee, what caused this situation to happen? So what does cause schizophrenia? Well, the fact is the causes of schizophrenia are not well understood. And this may be because there probably isn't one single pathway that leads to developing schizophrenia and schizophrenia spectrum disorders. Most researchers believe that multiple factors play a role: brain development, brain chemistry, genetics, risk factors, including substance use, and other environmental factors such as stress. All of these things may play a role. It's thought that these risk factors then in turn result in alterations in transmission of certain neurotransmitters in the brain. These are the chemicals that our brain cells naturally release when communicating to one another. And it's alterations in this communication that results, that is believed to result in schizophrenia spectrum conditions. With the next slide, we move right into the features of schizophrenia. And as we walk through these different features of schizophrenia and schizophrenia spectrum conditions, please keep the example person that David just presented in mind, and also keep in mind that every person's experience of schizophrenia is unique. There is no one single symptom or feature that is common to all persons with these conditions. However, there are several features that often or typically occur, and these include hallucinations, delusions, disorganized thinking, cognitive impairment, and some other features that will be discussed in the slides to come. So let's walk through these one at a time. On the next slide, we'll start out talking about hallucinations. Hallucinations are fairly common in schizophrenia and schizophrenia spectrum. And that word refers to hearing or seeing things that aren't actually there. As you might imagine, hallucinations can be highly distressing, very distracting, and confusing. Hallucinations are generally distinguished from illusions. And how are these two words different? Where hallucinations refer to seeing or hear things that aren't there at all, whereas illusions refer to misinterpretation of a sound, a sight, etc. Both can be distressing, but hallucinations are what's specific to psychosis and are considered a cornerstone symptom for schizophrenia. With that, I'd like to also ask Dave to join here, and I wonder if you might bring that into context for us, Dave, for how might a person experience hallucinations? What sort of features might you think about with that?
Absolutely. Thanks, Mark. I realized that earlier I didn't actually introduce myself, so I'm going to just do that quickly now. My name is Dave Leon, and I'm a licensed clinical social worker. I've been working as a social worker for 20 years and working in the mental health field for 25 years. And most of my focus has been with people with more serious mental health challenges, including schizophrenia. And my early career at D.D. Hirsch in outpatient mental health in Culver City was really focused on young adults that had experienced first break psychosis or were recovering from schizophrenia or schizoaffective disorder. I also started an organization called the Painted Brain, which is an arts and mental health organization, which is really dedicated towards trying to help people with serious mental health issues connect with each other, find ways to find meaning and purpose in art and shared experiences. And our community center is in Mid-City, Los Angeles. So I'm really happy to be here and talk to you all. Carl is much more open about his delusions, which we'll talk about in a minute. His hallucinations are a challenge for Carl. He hears voices that he doesn't like to acknowledge or talk about very much, and he does sometimes see things that he doesn't, that make him very uncomfortable and nervous. He's very uncomfortable talking about these things with other people, but they are a part of his ongoing experience. When he has opened up about his voices, some of the voices that he hears are very critical, telling him that he's not worthy or that he is ugly or smells bad, just really insulting comments on him. Other voices that he hears are actually kind of supportive and helpful to him, but he tends to keep to himself about these things. Thank you, Mark.
Thanks, Dave. So let's move on to the next key feature of schizophrenia, also a very serious symptom, and that's the symptom that we refer to as delusions. Delusions are another common feature in schizophrenia, and this word refers to constant, fixed, false beliefs that oftentimes sound bizarre to somebody as an outside observer. For instance, somebody might feel that the body of a person they know well has been taken over by somebody else entirely. Or another type of delusion, what we refer to as a paranoid delusion, might be a persistent suspicious belief that other people are intending to harm them in some way. Like hallucinations, delusions also can be highly distressing, can be quite preoccupying, and may result in a person engaging in harmful behaviors as an attempt to actually address that false belief. And I wonder if you could say more about that as well, Dave.
Yeah, Carl is actually pretty used to the language around delusions. He's been told that his thoughts are delusions for most of his adult life, and so he kind of adopts that language. But at the core, he really believes that the Earth has been sort of infected by another group of people from another planet, and that a lot of the evil and the badness that he experiences in the world that is part of our world is due to these aliens from another world. Um, he knows that most people see this as a delusion, but it's something that he actually believes. When he's in a good sort of having a good day, this isn't a huge distraction for him. But when he's stressed or afraid or feeling like he's going to be at risk in the near future, his anxiety and nervousness about this delusion gets more intense, and he gets more suspicious that people around him might be these aliens or have bad intention to him. And so it makes him very uncomfortable. He's quite open in talking about this, though, which is helpful to the supporter to know. Thanks, Mark.
Great, thanks, Dave. Okay, so we've covered hallucinations, we've covered delusions. Another serious feature of schizophrenia, as is displayed on the next slide, are disorganized thoughts and behaviors. Persons with schizophrenia also often experience disorganized thoughts and behaviors, especially when they're in an acute episode of the illness. When they're in this stage and experiencing disorganized thoughts and behaviors, they may have difficulty organizing their speech into what sounds to us like logical sentences, or they may have difficulty even staying on topic. And this makes it difficult, of course, to get basic needs accomplished, such as dressing appropriately for the weather, getting appropriate nutrition by eating correctly. Persons with disorganized thinking also oftentimes have difficulty with communication with others, of course, and in order to get their basic care and services. So, as you can imagine, this disorganization can lead to ongoing difficulties around obtaining food, shelter, maintaining personal hygiene, maintaining personal safety. And again, I think this might apply to our example person. And so, Dave, how might this play a role in the example we've been discussing?
Carl is usually a pretty coherent and pretty easy to understand and communicate with. But when he's more distressed, he does start to talk with less words. He keeps his words very simple. He doesn't move as much, and he tries to sort of keep to himself. His thoughts are not quite as clear when he's more distressed. Other people that I've worked with in the past, I'm thinking about a young man that I met a long time ago in a drop-in center in Hollywood who was talking at me with a lot of intensity and pressure and saying a lot of words, but didn't make any sense to me. And I could tell that he really wanted to connect with me. I'll probably talk about this later in our training, but what I suggested to him visually was just like, hey, let's sit down together. And we sat down across from each other at a table and started drawing with each other. And that was a way to sort of connect with this person who clearly wanted to connect, but wasn't able to connect through his words. The other feeling I got from him was just a really deep desire to be understood while knowing that he wasn't understood. And I could sense that anxiety with him. Another person I'm thinking about really just wasn't able to respond in any way. Their disorganization was kind of to the point where they were just sitting very still and trying to like minimize their experiences of everything. And so their responses to me were very, very limited. And a lot of what I did was try to just calm myself down to be with that person. Disorganized thinking can be very anxiety provoking to the supporter or to the person with them. I think it's really important for us to think about just how to calmly sit with somebody that's very agitated or uncomfortable. Thanks, Mark.
Thank you, Dave. And I like how you're beginning to bring in information about how we can be supportive to persons like Carl. So I love how you're bringing that information into some of this information that we're presenting here. Great. I know we're moving quickly, but let's move on to our next slide, where we'll be talking about a couple more terms that you may be hearing as you provide support to persons in the care program. And one of those words is psychosis. Before I get to that, though, I want to mention that persons with schizophrenia often have what we refer to as a wax and wane course of their illness. You might hear that phrase, wax and wane. What does that mean? What that means is of all of those symptoms that we've presented, and we'll actually be presenting some more, there may not be any one symptom that's constant for the person, that they may have a symptom or a period of illness for a certain period of time. It might get better and they're in a different state for a while. And so things might go up and down over time. And that's what we refer to as the wax and wane. So though many of the symptoms often are constant, others occur during episodes where the condition worsens. It's during these episodes where the conditions worsens that we oftentimes refer to acute psychosis. Acute psychosis refers to the experience of those symptoms that we just covered, hallucinations, delusions, disorganized thinking, but in a more intensified state. Persons who have psychosis, as you might imagine, are oftentimes in personal crisis. They may also start to have associated things like having suicidal thoughts. They may become highly paranoid, may be behaving in a disorganized, erratic way, may engage in risky behaviors, might be agitated, aggressive. And persons with who are having a psychotic episode are oftentimes highly vulnerable. And need our help, very acutely. And that acute psychosis oftentimes leads to having a person seen in an emergency room and maybe even psychiatric hospitalization. So that term psychosis, it can be a confusing term because not all persons who have psychosis have schizophrenia, as psychosis sometimes occurs with other types of psychiatric conditions. And a mental health professional is typically needed to evaluate if a person with psychosis has schizophrenia or if it's due to some other condition. And the risk of acute psychosis is higher in persons with schizophrenia who are not receiving treatment, and especially who are not receiving any sort of medication to prevent psychosis. And I know, Dave, we've covered each of those symptoms already. And I wonder how an episode of acute psychosis may be experienced by somebody like Carl.
Yeah, thank you, Mark. Carl is pretty reticent to talk about his more acute psychotic experiences in the past. They were terrifying for him, and he keeps them to himself. I wanted to reference actually, in thinking about this training and thinking back on my history and work, the first person I ever sat with that was in an acute psychotic state, it's more than 25 years ago, and I was in a group home in Minneapolis. And this young man, just a couple years older than me at the time, so mid-20s, was very, very overwhelmed by his thoughts. He was very intensely focused on sitting still and just keeping it together. And he was just almost physically holding himself together. And I sat with him for a long time, and he was in the state of sort of waiting till the morning when we would transfer him into a psychiatric hospital. And he knew he wanted to go there because he was really afraid. And while he was sitting there, two things happened. One is that he drew a perfect circle on a piece of paper very slowly in front of me, which I've never seen anyone do. It was amazing. Perfect concentration. It was a perfect circle, just hand drawn like that. And then he looked up at me and he picked up a cigarette and he said, "Is this cigarette going to give me cancer?" And I had to think about, like, what do I say to this? And I said, cancer is something that can happen to people that smoke, but I don't think that cigarette is going to give you cancer specifically. If it's going to calm you down to smoke that cigarette, maybe that's an okay thing to do right now. And actually, that was a lot of what got me sort of interested in working in this field generally. It's like meeting people with that kind of extreme mind experience. It's just fascinating, but also really, really very emotionally intense. So thank you, Mark. I hope that was a helpful example of a acute psychosis.
Thanks, Dave. That was very helpful. Well, we've covered a lot of things already in this presentation, but there are actually additional features about schizophrenia spectrum conditions that we'd like to present. And to take us through some of those, I'd like to hand the microphone to our colleague, Deborah Rose.
Thank you, Mark, and thank you, Dave. It's a pleasure to join you today, and I'm very happy to be here to talk about some of the features of schizophrenia and other schizophrenic spectrum disorders. I've already heard a lot and learned a lot from you, and so I'm eager to continue that conversation. One of the significant features for people living with schizophrenia is really an absence of an awareness or a self-awareness, ability to recognize or understand their own symptoms. And while we might see somebody living with schizophrenia, what appears obvious to us to be an acute symptom, for that individual, it's often very difficult to recognize it. And there's a word that clinicians and people might use to describe that, which is anosognosia. And so you'll hear that word, which essentially means it's an inability to recognize symptoms or an illness in oneself. Sometimes that lack of awareness makes it more difficult to provide informed consent, makes it a little bit more difficult for folks to understand the implications of behavior, of treatments that may be offered, of impact on relationships. And so it can sometimes make it more challenging to provide services and to support people and engage them in their care and treatment. The features that we've been talking about so far, hallucinations, delusions, disorganized thinking, disorganized behavior, psychosis, acute psychosis, those are many of the things that we talk and think about when we discuss schizophrenia, and they receive a great deal of clinical focus. The people living with schizophrenia have some symptoms that could exist even when they are not experiencing an acute episode of psychosis. So these features can present themselves earlier. It could be an early indicator of what's to come. And some of these features can suggest that there will be a greater impact on that individual's life later. So to give a couple of examples, diminished facial emotional expressions. Sometimes people living with schizophrenia have a difficult time expressing their emotions. The features may seem flat or blunted. Sometimes it's seen as a difficult time making eye contact or raising or lowering speech. You might hear changes in somebody's intonations, or maybe even difficulty expressing by body language, excitement or sadness. And so that stunted emotional expression may be common that we see when we're working with individuals. Another common feature that we see is a lack of motivation or reduced motivation. Sometimes people living with schizophrenia withdraw from things that maybe brought them pleasure or joy before. Sometimes they withdraw from relationships. Perhaps these are folks who had great activities, sports, hobbies, interests, connections to family, loved ones. And an unfortunate feature with schizophrenia is that those things that were once really important and treasured may be less interesting, less appealing, less valuable to the individual as a result of some of the symptoms. Certainly, one feature that we'll see is an impact on how one thinks and judges and interacts. It looks different in different people. It could come across looking like difficulty paying attention, difficulty organizing complicated tasks. Things that require multiple stages and management can be a challenge for folks. Sometimes learning new information or remembering information, some basic things like phone numbers or addresses. The cognitive or the thinking aspect of schizophrenia is really about the difficult time paying attention, staying on tasks, organizing tasks, learning new tasks. And it's important to remember that that person living with schizophrenia isn't intentionally not paying attention. They're not intentionally distracted. They're not intentionally disregarding the importance of these features or of these tasks. But it's a very real symptom related to somebody's symptoms, and it's a result of their condition. So putting this all together, the impaired judgment, logical thinking, or a difficult time with some logical thinking, to the outside person, it could just look like bad decisions, bad choices, but it really is a constellation that are all tied directly to the symptoms of a person who's living with schizophrenia. Some additional things that you might see as part of that could be substance use, could be self-medicating by the use of substance use, could be alcohol use. And so again, this combination of reduced motivation, of perhaps diminished or flattened affect, and then of some impact on how somebody thinks and makes judgments and process these thoughts together are some of the features that we may see with somebody who's living with schizophrenia or other schizophrenic spectrum disorders.
Carl is a person who has different moods on different days, and his mood affects sort of how his presentation appears to other people. So sometimes when he's in a sort of calmer state, he's actually a very expressive and emotional person, and maybe almost more expressive than other people. Like his emotions almost move faster between them than sort of a more neurotypical person. Other days when he's more afraid or facing something that's hard, his emotional presence seems to flatten. He gets more serious, less movement on his face, and more of a fixed stare. And you can kind of judge, I think, where he is in the world based on where his sort of physical presentation and emotional presentation is. The more flat for Carl, probably the more stressed he is, and the more anxious he is about something. The motivation is an interesting question too. I've had several experiences working with young people who, to the outer looks, seemed like they were sitting still on a couch for 12 hours a day, not moving. And I mean, that was physically what was happening. But when you understand what's going on in their mind, one young person was living in a very complicated fantasy world that he had created. And he was in action in his mind throughout that whole day, imagining himself in different experiences. Another person was very motivated to do something other than sit on his couch, but also extremely afraid of making any physical move to do that. So it wasn't so much a lack of motivation as a frozen state of fear of actually making an attempt to do something different. So a lot of times with people with schizophrenia, what you're seeing on the surface is an indication possibly of what's going on the inside for that person, but you don't know, and it might be important to ask or sort of question the assumptions that you make. Thanks so much.
And I wanted to jump in here a little bit and just sort of describe a bit from the clinical perspective how this might be experienced by us, because that reduced motivation, difficulty with paying attention. It's important for us not to lay our attitudes on people and kind of say, oh, they're lazy, or they're not taking this seriously. But these are actually features of the condition that they're experiencing themselves. And this is especially important because in our work, we oftentimes get very busy. Clinics can be very busy. And I would imagine care court, there's going to be times when it's going to be pretty busy and people want to move along very quickly. And the person who we're trying to help, the person experiencing schizophrenia, may have difficulty going at the pace that we would like to go to. So we really need to remind ourselves that we may experience frustration, but we really need to slow ourselves down a little bit and check on ourselves so that we don't inappropriately hustle people through a system. It's especially true because also systems like this, there tends to be lots of paperwork, tends to be lots of forms. And we need to slow down and kind of go through things sort of one at a time to make sure that someone like Carl is on track with us as we're going through these steps. Thanks, everybody.
Thanks, Mark. So let's talk a little bit about what it looks like when schizophrenia first presents itself. Often we'll hear about older adolescents, young adults, late teenage years, early 20s. Sometimes you hear about young folks who are going to college who come back thinking a little bit differently. typically schizophrenia, early symptoms of schizophrenia come in the late teenage years, the early adult years. Again, that 18 to 24-year-old period. It's really essential that in the very beginning, that mental health professionals, folks like Mark, like myself, I'm a clinical psychologist who have been working in this field in clinical services for 20 years. Licensed social workers, others are involved in those early phases to help identify some of the symptoms and potentially make a diagnosis that's really based on 6 months of symptoms, and that follows the 6 months of symptoms, the specific features that we look for. And it's really important, I think, that the individual is working with professionals to ensure that there aren't other features, that maybe that there aren't other illnesses, other conditions, other contributions to the presentation. So again, schizophrenia typically is seen late teenage, early adulthood, and then it comes after a few months, 6 months of symptoms. So how is somebody with schizophrenia diagnosed? As I mentioned in an earlier slide, schizophrenia is diagnosed by a mental health professional, somebody like myself, like Dave, like Mark, who's trained in working with individuals living with mental illness, living with substance use. There's a very specific set of diagnostic criteria that we might use, and we'll follow those. It's called the DSM, the Diagnostic Statistic Manual. It's a big name for a big book. Professional will work with the individual and his or her natural supports, family members, loved ones, people that are important to the individual, ideally, to gather information, to ask a lot of questions, and to look at what are the different features that we're seeing. Typically, the diagnosis is made after at least 6 months with signs of the illness. There is no blood test. There's no single marker for schizophrenia. It is important to have physicians who are working with the team to do blood tests and other procedures to rule out other conditions that could be contributing to the presentation. And I think Dr. Avery can give her a couple of examples, but there's no one specific blood test or lab result that's going to indicate a diagnosis of schizophrenia.
Yeah, that's right. As I mentioned, that there are other conditions out there that can cause those symptoms that we refer to as psychosis. So it's actually extremely important that, especially as people are initially being assessed for schizophrenia, that they get the appropriate workup to make sure that there's not something else that may be causing these symptoms. But as Deborah said, sometimes that gets confusing. Like, why are you drawing this blood test? Is this to help diagnose schizophrenia? But as Deborah said, there really isn't a blood test for schizophrenia per se. So it's important to clarify that. Thanks, Deborah.
Thank you. Why don't we go to the next slide? And Mark, I think that you can continue, please.
Yeah, so at this point, we'd like to point out that the category of schizophrenia, spectrum disorders, and other psychotic disorders actually includes many different diagnoses, often with very similar sounding names, as depicted here on this slide. These diagnoses are all clumped into one grouping in our book of diagnoses because psychosis is a feature to all of them. However, there are other conditions where other people might experience psychosis and still not have any of these conditions. And as we just mentioned, even sometimes, like a medical condition could end up causing symptoms of psychosis. So it's important to be appropriately assessed. Also note that most, but not all of the conditions displayed here on the slide are those conditions that are deemed to make you eligible for the CARE Act. So, and I want just to point out here that we're talking a lot about diagnoses and symptoms here, but please remember that people are far more than their diagnosis. They're far more than their symptoms. Everybody is unique and their experience is very unique. And so diagnosis is really just one aspect of the individuals that are going through the care process. For more information about what I just covered on this slide about eligibility and diagnoses, please refer to the CARE Act eligibility criteria fact sheet or additional trainings on the website where we cover this in greater detail. And with that, I think we're ready for the next slide. And back to you, I think, Deborah.
Thank you. So let's talk a little bit about what some of the associated diagnoses are, what some of the conditions aligned with people living with schizophrenia. Unfortunately, people who are living with schizophrenia or other related diagnoses are really at risk for additional diagnoses and additional conditions. Some of these may include things as a result of genetic components, as a result of some of the trauma, and we are going to talk about trauma-informed care. And we'll refer you to some information that we've created on trauma-informed care. Some of it's connected to stress and other environmental factors, like the term adverse childhood experiences. You might hear about ACEs, or adverse childhood experiences, down the road. So some examples is that a person with schizophrenia may experience some depression, which may lead to a formal diagnosis of depression in addition to the diagnosis of schizophrenia. They may be exposed risk for trauma. We do know that people who are living with schizophrenia and other serious mental illnesses have higher rates of victimization by the very nature of living conditions, and by stigma, and by violence that they experience in the community. So people who are living with schizophrenia would tend to be at greater risk for post-traumatic stress disorder and other trauma disorders. People are also at higher risk for substance use, including alcohol, tobacco, other kinds of substances. People are more likely to use cigarettes, which can sometimes help reduce stress, but also puts them at risk for other medical complications. It's sometimes used for soothing, for self-soothing. And so along with the condition of schizophrenia, we do need to consider the entire individual and the impact of other conditions and other complications that will impact that person.
Yeah, I'd like to jump in, Deborah. Thanks. One of the best quotes I ever heard from a speaker was a man who said, you know, I have schizophrenia, but I don't suffer from schizophrenia. I suffer from stigma. And I think that a lot of what people experience is really about what society's reactions to the symptoms and the sort of experiences of people with psychotic disorders and schizophrenia often causes a lot of the sort of societal challenges that they individually face, including homelessness, incarceration, social detachment, loss of friends that can't really understand or relate to what the person's going through, reduced self-care, thoughts about suicide and self-harm, are all factors of really schizophrenia, but also of poverty, of social exclusion, of feeling like you don't fit in the world. And all of these situations are partially due to the symptoms and the sort of illness of schizophrenia, and partially due to our society's reactions to people that have this illness. Another sort of likely outcome is poor health outcomes. People with schizophrenia are at risk in all these different ways, and all of the things that we just mentioned can increase people's sort of health risks: homelessness, incarceration, poor access to services, poor access to healthy food, can all lead to poor health outcomes.
We're at the second to last slide here. And so pulling all this together, everything we've covered so far in this part of the training, in summary, schizophrenia is, of course, a serious psychiatric illness with, very serious symptoms related to thinking, emotions, and behaviors. But it's important to recognize that each person's experience is unique, even at the levels of severity. Some have less severe experience, others have more. Every person's experience is unique, and that with appropriate supports and services, each person with schizophrenia has the potential for leading meaningful and fulfilling lives and experiencing quite a bit of recovery. So far, we've covered the basics of this condition. In part 2, we'll review the available treatment and service options for persons with schizophrenia, followed by part 3, where we'll talk about how you can effectively work with and support someone with this condition. And to take us to the next slide and to take us home here, I'd like to call in again my colleague to sum up what we've talked about so far.
Hi, I'll just share a little bit about sort of where Carl falls in on all this. Carl is a person who has been diagnosed with schizophrenia and has been part of his life for most of his adult history. But when you ask him who he is as a person, he's a person who loves Queen and loves classic rock. He loves his dog. He's really devoted to his friends. And his identity is really not based around schizophrenia. It's around the things that he has in his life and the connections that he has in his life. Schizophrenia is a major factor of his life, and he knows that, and he sort of faces every day with that awareness. But the first thing that he would want you to notice about him is not that he has an illness, but that he has, a sweet little dog and a real love of classic rock. And so I think it's always important to think about the person before you think about the diagnosis. Thank you all.
Thank you, everyone, for that discussion and for talking through some of the basics of schizophrenia and beginning to speak to how people can provide support and better understand some of the features and complications and how the supporter might fit into that role. So the objectives for this session were, again, to be able to use specific language related to schizophrenia about some of the features and some of the symptoms